Amaria, as Jen mentioned. I'm going to go ahead and try to share my screen here. Please let me know if there's any issues. Are you able to see my full screen? Okay, great. So yeah, thanks Jen. I'm Rodabe N Amaria. I'm an associate professor here at MD Anderson, and today I'm going to be talking about one of my favorite subjects, which is neoadjuvant therapy in melanoma. Here are my research disclosures, just talking about my clinical trial support. So let's first, in order to understand neoadjuvant therapy, we need to define it, and we need to differentiate neoadjuvant from a term called adjuvant, which some of you guys may have heard of. So let's take this patient as an example. This is a 37-year-old man who has a melanoma on the temple. As you can see here, this black area that's circled, that's a primary melanoma of the temple. And as you can see here circled in red, this is an area of swelling in the neck, and that corresponds to a lymph node that is full of melanoma, which is making it obviously bigger and sort of protruding from the skin. So at this point, when we meet a patient like this is somebody who's going to require what we call a multidisciplinary approach. This person needs to see not only a medical oncologist like me, but a surgical oncologist who would consider doing surgery. And there's another important point. This patient, by definition, has high-risk disease. If you make enough melanoma, if you grow enough melanoma that you can actually see it and feel it, that, by definition, is a patient that has a high risk of developing distant disease in organs of the body or having recurrent disease after surgery. So this is a very high-risk melanoma patient. So when we see a patient like this, there are really two options. The first option would be to proceed with surgery up front, and then after surgery is complete, to have what's called adjuvant or postoperative therapy. There's another, so that's the main approach we've used for years. That's been our standard, tried and true approach. And the reason why we've been a little hesitant about continuing on with this approach is that we've realized that people that have been treated in this way really have a high risk of disease recurrence. And although we've made a lot of progress with postoperative medical therapy or adjuvant medical therapy with some really great drugs that have been FDA approved in the last couple years, there's still a really high chance of this patient developing recurrence down the road, even with our state-of-the-art new therapies. And so we've tried to think outside of the box here at MD Anderson, along with a lot of other sister institutions, and have come up with this kind of an approach. So in this approach, instead of the patient proceeding directly to surgery, we would do a neoadjuvant medical therapy or preoperative therapy. So we would give some medication prior to surgery for a limited period of time. Then the patient would go to surgery, and then they would have therapy after the surgery, that adjuvant therapy that we already talked about. Now, this seems a little cumbersome, I think, with all of these different arrows and different types of things that we're doing, but why would we actually do that? So, you know, there's, I think, a lot of potential things that neoadjuvant therapy can help with. Number one, it's very easy to understand that if you administer some highly active therapy, you can actually watch that melanoma melt away. That lymph node can actually shrink down. It can really shrink down significantly, and that may make surgery a little easier, maybe make the surgery a little less involved if you have a good response and you're able to really shrink the disease down. The other important point is we know that when a patient has grown enough melanoma that you can see it and feel it, that melanoma has been there for a while. So you can kind of think of the melanoma having a significant head start on us. And so there's the risk of the melanoma being localized in a lymph node, but there's also the risk of the melanoma leaving the skin and the lymph node and getting into the bloodstream and be waiting to sit down and grow on an organ like the lung or liver or something like that. So if we start medicine up front, we may be able to, the goal would be to not only shrink the disease we can see and feel, but hopefully prevent any microscopic disease from popping up in organs down the road. Another important thing is that if we give a neoadjuvant therapy and it doesn't really do very well, well, we learn about that. And that way we could help to tailor the postoperative therapy to something that might be different that the patient may respond to a little bit better. Another important feature with neoadjuvant therapy is it really helps us to understand patients that have the best prognosis. So there may be a subset of patients that get the treatment in the neoadjuvant setting, and their melanoma may be completely dead or almost dead at the time they have surgery. Our pathologists can actually quantify for us how much melanoma is living or dead at the time of surgery. And those patients that have melanoma that's completely dead, which is something we call a pathologic complete response, we can have definitive data to suggest that those patients have improved outcomes over those patients who get the therapy and don't do as well. And again, that helps us to really tailor their postoperative therapy and to figure out how closely we need to be watching them after the surgery is complete. Another important feature is that we really can learn a lot from doing neoadjuvant therapy by getting blood and tumor samples across the time period that the patient is getting the neoadjuvant therapy. So if you do a sample, a biopsy, and a blood draw prior to treatment, and then during treatment, and then at the time of surgery, you now have 3 sets of blood and tumor, and we can look and do very detailed analyses of both the blood and tumor to figure out why patients are having, say, a great response to the treatment and why people are not having a great response. So we really can try to figure out predictive markers to try to figure out which patients are going to get the most benefit and which patients are not going to do well with that kind of treatment that would need a different kind of a therapy. So it really helps us understand on a personalized level why a patient does well or not, and that will hopefully help future generations of patients. Another important thing to understand is that when you give a drug in this kind of setting, this is really an amazing drug development tool. And what I mean is that I'm sure you all know that when we're trying new drugs and doing clinical trials, it takes years and years and tons of patients on a specific drug before there's ever enough data to get it FDA approved. But if you do a neoadjuvant therapy trial, you can actually treat a small number of patients, and by getting blood samples and biopsy samples and doing really deep analysis of the blood and tumor and correlating the findings in the blood and tumor with how a patient is doing with shrinkage of disease and their overall outcomes, you can actually help get so much information from just a few treated patients. So drug companies can often use this as a way of trying to figure out, oh, this is an awesome combination of drugs or new drug. Let's, really invest all our resources in this and trying to get it FDA approved. Or maybe this isn't as good as we would like it to be. Maybe we need to take it back to the drawing board. So we really get a lot of information from treating just a few patients on this kind of clinical trial. Now, there's obviously a downside to this. So, of course, if we give the therapy and if it gives side effects, well, treating those side effects can often cause a lot of problems, and it can certainly delay or maybe prevent the surgery. I think that this is something that happens really a minority of the time. I think if you're getting this therapy, you're talking routinely with your treatment team, usually we can pick up on these side effects and implement the treatment that we need to get the patient safely through the side effect and safely to the surgery in a realistic time point. The other thing that we have to think about is that if we give this therapy and the patient's disease doesn't respond, and if they actually develop metastatic disease or the disease spreads to other organs of the body, then obviously we've lost the surgical window because the patient, has metastatic disease. Obviously, this is the worst case scenario. But my argument here is that we've learned that this patient truly has aggressive disease, and doing a surgery wasn't going to cure him anyway. So I think even though that's a potential downfall, it does help us to really understand an individual patient's disease course and the aggressiveness of the disease. So with that kind of detail in place, I think neoadjuvant therapy is really something where, unfortunately, right now, it's not the standard of care in melanoma. It is the standard of care in cancers like breast cancer or rectal cancer or gastric cancer. Neoadjuvant therapy has had a long history of having a place and a role. But in neoadjuvant therapy in melanoma, we have an idea that we think it would be helpful, but we haven't ever really crossed the finish line of getting a drug or a combination of drugs FDA approved for neoadjuvant therapy yet. And so really, neoadjuvant therapy in the last couple of years is still in its infancy. And so we've really had to organize ourselves internationally amongst the melanoma community to develop guidelines. And so far, we've developed guidelines that have been published and widely distributed, helping us understand how best to, number one, design a clinical trial so that we get all of the learning we possibly can get out of it. And we've also published guidelines on how best for the pathologist to look at the treated surgical specimen and how to analyze it and how to quantify if the melanoma is living or dead. And so in the last couple of years, we've published these guidelines, and that's really helped to spur a lot of really cool clinical trials and research that's been done. And here's just a snapshot of some of the clinical trials and the publications that have resulted. We are now at the point where we're really poised to run a clinical trial where we're trying to get neoadjuvant therapy as an FDA approval. And I think it's because of really the buy-in of the melanoma community as a whole, and buy-in of not only the medical oncologists, but the surgeons, pathologists, and everybody else that's involved with trying to bring neoadjuvant therapy to our melanoma patients. So to summarize this portion of the talk, neoadjuvant therapy, does really provide an opportunity to help improve patient outcomes in a really high-risk patient population that would have a high risk of recurrence with having upfront surgery and then adjuvant therapy. If we do neoadjuvant therapy trials well, we can actually really learn a lot, not only from how a patient tolerates the drugs or how much their melanoma shrinks, but we can actually analyze blood and tumor as research tools to help us understand why patients respond or don't respond as well to the therapy. And finally, neoadjuvant therapy is really a team sport, and we have to have early engagement and teamwork of our medical oncologists, our surgeons, our pathologists, and our radiologists, everybody that works together to try to make neoadjuvant therapy successful for our patients. So I will stop there